Hello and welcome to Chapter 16, Hypoproliferative Anemias. So hypoproliferative anemias are a heterogeneous group of acquired and inherited disorders where here you see this is a cross-section of a bone marrow that is completely hypocellular, where the tissue in the bone marrow is replaced by fat. On the peripheral blood smear, you will notice, and from the CBC results, that this is a normocytic normochromic or macrocytic normochromic type of anemia. Here, the hypoproliferative anemias are categorized into aplastic, aplasia, or hypoplastic, meaning that the bone marrow has an overall decrease of hemopoietic cellularity. So the decreases can be either in erythroid, myeloid, and or megakaryocytic hypoplasia. So you can have decreases in all three of the cell lines, red cell, white cell, and platelet, or you can have just a decrease in one cell line, for example, the red cell. Now here is a cross-section of a hypoplastic anemia with the bone marrow being replaced by fat on the left-hand side, and on the right-hand side you see a normal cellular type of cross-section. Here the defect is due to a depletion or damage or some kind of inhibition of the stem or progenitor cells. So again, if there's only a unipotent erythroid progenitor problem, only the red cell line is affected. The white cells and platelets are normal, and this is called a pure red cell aplasia. Now, if you have a multilineage defect that includes the white cell, platelet, and red cell, all three of these will be decreased, and the term will be called pancytopenia, leading to an aplastic anemia. Talk a little bit about aplastic anemia. So you normally have the bone marrow, which makes up all the healthy cells in your body, but with aplastic anemia, you see that the marrow is producing very few healthy red blood cells. And here you're seeing pancytopenia is associated with the hypocellular bone marrow. The mature cells appear normal, but with disease progression, all cells are going to become depleted. Impaired capacity of the bone marrow to renew any cells. Discuss criteria for aplastic anemia. Please note Table 16.1 is a very good studying measure, as this is the diagnostic criteria. So the cellularity of the bone marrow has to be less than 25%. And to be classified into the aplastic category, your white cells have to be less than 0.5 times 10 to the 9, your platelet count has to be less than 20, and your anemia with your corrected reticulocytes have to be under 1. So let's talk about the epidemiology of aplastic anemia. First, it is very rare. It is most commonly seen in either children under 5 or a 15 to 25-year-old group, which again, there is a higher incidence, or in adults over 60 years old. Now, children are usually occur from an inherited problem, where adults, it usually occurs in an acquired form. The acquired or immune-mediated diseases happen from a suppression of a stem cell growth and differentiation, usually by abnormal cytotoxic T lymphs. The stem cell concentration in severe types of acquired aplastic anemia usually has less than 1% normal cells. Here you have a defective telomere maintenance in the stem cell or progenitor cell, which reduces the proliferation of precursor cells, increasing apoptosis. So this is observed in acquired and inherited types of aplastic anemia. So 16.2 is another good classification of hypoproliferative anemias, categorized into aplastic, which can be acquired or inherited. This leads to a pancytopenia. Again, it is a decrease in your white cell platelets and red cells. Or you have categories of pure red cell aplasia, which is only the red cells that are decreased. Your platelets and your white cells are normal. And again, there is always another type of hypoproliferative anemia, which usually causes either some kind of renal disease or other kind of endocrine abnormality that causes a decrease in usually EPO or production of red cells. So let's talk a little bit about the drugs or chemicals causing acquired aplastic anemia. Majority of the cases are idiopathic, meaning they cannot be linked to any environmental factors. There are certain drugs that recent research has shown that early exposure is associated with aplastic anemia. There are chemical agents such as toxic chemicals in the industry, such as pesticides or benzene derivatives, that can cause aplastic anemia. For ionizing radiation, so industrial accidents, military nuclear tests, or certain types of therapeutic regimens for malignancy can lead to a hypoproliferation of cells within the bone marrow. Now, effects of irradiation are dose dependent, and if you give greater than 4,000 radiation units, there is irreversible damage. Now again, infectious agents can also cause aplastic anemia. So they can be caused either by viral or bacterial infections, and usually it's followed by a transient cytopenia. This can be limited to the red blood cell line or to include all 3 cell lines. A lot of the infectious agents are infectious mononucleosis, tuberculosis, causing hepatitis. Other kinds of viruses, Epstein-Barr or HIV, have been known to cause aplastic anemia. Or other types of hemolytic anemias, patients with parvovirus can develop an aplastic crisis. There can be metabolic causes of aplastic anemia, such as inborn errors of amino acid metabolism, starvation or protein deficiency, or it can happen in pregnancy, but it's very, very rare. So Fanconi anemia is an autosomal recessive inherited type of aplastic anemia that is a molecular defect caused in childhood. You're seeing abnormal chromosome fragility. Look at the arrows on the left. And these patients unfortunately have an increased disposition to leukemia or cancer. The complex assortment of congenital abnormalities include progressive bone marrow hypoplasia, as seen in the image C below, dysplasia of bones, so look at the structure of the hands in the image A. You have renal abnormalities, other malfunctions, mental retardation, dwarfism, skin hyperpigmentation. Like this image in B, you have they kind of look like birthmarks or cafe au lait types of hyperpigmentation. Now, Fanconi anemia has hematological manifestation as well. There is slow progression from birth. The clinical signs of pancytopenia usually appear between the ages of 5 and 10, where it's going to present as a macrocytic anemia, but again, it can be normocytic. Red cells tend to have an increase in hemoglobin F, and again, you're going to see a leukopenia and a thrombocytopenia. For treatment, The only possible curative treatment is a stem cell transplant. But again, risk of developing cancer increases with age. Now, here's another inherited aplastic anemia, which is a congenital disorder leading to aplastic anemia called Schwachman-Diamond. It has the same congenital anomalies, except it doesn't have increased chromosome fragility or defective DNA synthesis. Here we have a rare inherited bone marrow failure characterized by a low number of white cells, poor growth due to difficulty absorbing food, and in some cases, skeletal anomalies. Now for aplastic anemia, the symptoms usually take a while to develop, usually related to the cytopenias. The most common signs are bleeding or petechial or big bruising all over the body due to the low platelet count. With the anemia, you might see pallor and fatigue just generally as a normal type of anemia. And because of the low white count, these patients commonly have recurring infections. Now, in the peripheral blood for pancytopenia, you'll see a decrease in the red cell count, a decrease in the hemoglobin count, and the hematocrit. Remission data, it is not uncommon to see a red cell of 2.4 or under 3 and a hemoglobin of less than 8. Now here, the platelet count is less than 20, as in the criteria suggests, and look how low the white cell count can go, down to 1.2. In the peripheral blood, you're going to see normocytic normochromic cells, or they may be slightly macrocytic. Now your reticulocyte will be under 25, and your RPI will be less than 1 because your bone marrow cannot compensate at all for producing any of these cells. Thrombocytopenia, in this case, is present at the diagnosis. You might have a relative lymphocytosis because your neutrophils are decreasing, and the granules in your neutrophils may be larger or stain a dark red. And here is a bone marrow preparation from a patient with aplastic anemia showing marked hypocellularity. Now from the CBC, you have to do a bone marrow. A bone marrow aspiration and biopsy is necessary for diagnosis of aplastic anemia. Here you're usually seeing it hypocellular with greater than 70% fat. Now a lot of the times, because it is fatty, you might get a dry tap, meaning the bone marrow is infiltrated with so much fat, it leads to fibrosis and you cannot pull out any red blood cells. Again, you might see an increase in hemoglobin F, and the EPO is usually often increased to try to produce more cells. So what does prognosis and therapy look like for aplastic anemic patients? So hematopoietic stem cell transplantation is possible with a suitable donor. Also, immunosuppressive therapy can be accomplished if the patient lacks or cannot find a suitable bone marrow donor. Usually, there is a 5-year survival rate at about 79%. But first, again, if it is acquired aplastic anemia, you want to remove the causative agent and then provide supportive care. Now, if it is inherited, you want to try the bone marrow transplant first, and if there is no suitable donor, try immunosuppressive therapy. So initially, upon CBC presentation, you could have a pancytopenia. You need to differentiate the causes of aplastic anemia from other causes of pancytopenia. Pancytopenia, that is not related to aplastic anemia usually is not the result of a defect in the stem cell proliferation. So here we have bone marrows. In other causes of pancytopenia, the bone marrow itself will either be normal cellular or hypercellular. In causes of aplastic anemia from hypoproliferative disorders, the bone marrow itself will be hypocellular. So in differentiating pancytopenia, upon CBC, you will notice that you have a white cell decrease, platelet, and red cell. From here, you're going to order a bone marrow biopsy. This will distinguish between types of aplastic anemia and other types of disorders. So if your bone marrow is hypocellular, you know you have some sort of aplastic anemia caused by the things that we have already discussed. Now, if the bone marrow is normal cellular or hypercellular, you can get into conditions of marrow replacement or clonal disorders. So the first type of abnormality would be myelocytic anemia, which the bone marrow is replaced by fibrotic or neoplastic cells. So it reduces the normal amount of cells coming out of the bone marrow. It disrupts the architecture of the bone marrow, and usually anemia is present. Now here, the white cell counts and platelets can be decreased, but again, not to the aplastic criteria, and the production of the bone marrow is usually normal to hypercellular. You're going to see a lot in the peripheral smear with decryocytes because they're trying to squeeze out of the bone marrow, or large and bizarre platelets. Another type is a clonal heme disorder categories, where you have pre-types of leukemias, where they often terminate into acute types of leukemias, where you have pancytopenia, bicytopenia, or isolated cytopenias, causing a macrocytic type of anemia. Here, the bone marrow are usually normal to hypercellular, but you have some sort of dysplastic hematological cells coming out of the bone marrow. Now, another type of condition is congenital dyserythropoietic anemia. It is very rare type of refractory anemia that doesn't work with any treatment. And again, the major distinguishing factor is the bone marrow, where it is normal to hypercellular. So let's talk about another category, pure red cell aplasia. This is categorized by a selective type of lineage, where the selective hypoproliferation is committed to only the red cell line. Look here at the CBC results. You have a normal leukocyte and normal platelet. Your corrected reticulocyte, or your RPI, is less than 1, and the causes could be either acquired or inherited. So in Table 16.3, you have the lab findings in pure red cell aplasia. Definitely your red cell hematocrit and hemoglobin will be decreased, and so will your reticulocyte count. So please use these tables as a studying tool. Now, in the bone marrow, you're going to see an absence of precursor cells. So see the arrows? Usually your myeloid to erythroid ratio is 3:1. In this slide where the arrows are pointed, those are the only 2 red cell precursors in the bone marrow. So it is definitely severely decreased. Higher types of pure red cell aplasia can be caused by viral infections, bacterial infections, or drugs or chemicals, similarly to aplastic anemia. Let's talk about an inherited form of pure red cell aplasia called Diamond-Blackfan Syndrome. It is a rare congenital progressive red cell aplasia occurring in very young children. The symptoms of severe anemia appear in the first year of life, and there is no leukopenia or thrombocytopenia. The inheritance pattern is either autosomal dominant or recessive, and usually caused by an RPS19 gene mutation. In Diamond-Blackfan, you're going to see EPO levels being increased as there is an intrinsic defect of the erythroid progenitor cells, resulting in the ability to respond normally to inducers of proliferation and differentiation. You're going to see a severe type of anemia and only erythroid hypoplasia in the bone marrow. You'll also see certain types of bone dysplasia as well. Therapy for Diamond-Blackfan are usually red cell transfusions, adrenal, corticosteroids, and iron chelation therapy. Most deaths are due to complications of hemosiderosis. Diagnostic criteria for Diamond-Blackfan is a macrocytic or normocytic normochromic anemia in the first year of life, reticulocytopenia, normocellular marrow with marked erythroid hypoplasia, meaning that only the red cells will be decreased within the bone marrow. EPO will be increased, and you might have a normal to slightly decreased leukocyte count and a normal to slightly increased platelet count. So let's talk about other hypoproliferative disorders. First, let's talk about renal disease, which is a common cause of anemia that decreases hemoglobin and red cells. The pathophysiology, again, kidneys produce EPO, and it is decreased in kidney disease. You have a decreased red cell survival. You can have a blood loss from the GI tract for priming of dialysis, or dialysis patients are usually folate deficient, causing the type of anemia. Here you'll see a normocytic normochromic anemia. Hemoglobins are usually around 5 to 8, RPI is about 1, and you might see some moderate anisocytosis. You might see echinocytes, spherocytes, nucleated red cells, and again, platelets and white cells are normal. The bone marrow findings are the red cells will be hypoplastic. Therapy for this, renal transplantation, hemodialysis, or continuous ambulatory dialysis helps treat the anemia. And lastly, endocrine abnormalities is usually associated with the decrease in EPO because it causes a signal from the anemic state. If there is no signal, the kidneys won't know they need to produce EPO. Here you'll see a normocytic normochromic anemia that's mild to moderate, normal red cell morphology and survival, but the bone marrow will have a decrease in the erythroid cell line.